Cast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Rob Specker, and welcome to the June 9th Plan Management Advisory Committee. I'll ask Sana to identify the committee members that are here today, as well as board members. We'll have James give a quick update just regarding what's happening with virtual and in-person meetings, and then we'll hop into the agenda. Sana, if I could ask you to identify committee members and board members present, please.
Yes, good morning, everyone. Thank you for joining us. We have from the Plan Advisory Group members, we have Anthony Chen, April Martin, David Brabender, Douglas Brosnan, Hector Hernandez Delgado, John Newman, Rick Crum, and then obviously Rob. I'm just going to quickly scroll and see if anyone else has joined us. The attendee list is ever growing. And from the board, we have Jerry Fleming and Diana Douglas from the Plan Advisory members.
Great, thank you, Sana. James, if you're ready, could you just give an update as some meeting logistics?
Yeah, thanks, Rob. Yeah, so it's always been my intent to mirror the board as much as possible with our meetings, and the board has been meeting in person, and so I wanted to move the Plan Management Advisory Work Group meeting to in-person. But a couple of things came up which led to a bit of snafus for this month. One is we weren't sure if we were going to have a Plan Management Advisory meeting for June. We ultimately decided we needed to, in large part because of the mental health parity discussion that we'll be having later. But as a result, people didn't get much advance notice of an in-person meeting, and some people couldn't. Quite a few people didn't or weren't able to make the travel arrangements to make it here. And of course, as COVID case rates have increased, we're a little concerned about having everyone meet in a small room like we have in the past. So we decided to go all virtual this time. And in order to avoid this confusion in the future, I'd like to make sure that the board members, or not board members, the work group members know that we'll give you at least 30 days advance notice of when we will be meeting in person, so that you can make sure you can make travel arrangements as needed to show up in person. And with that in mind, we want to talk about July's meeting. Currently, there's no board meeting scheduled for July. I don't expect us to have a July Plan Management Advisory Work Group. There's only one case in which it will, to my mind right now, and that is if the either California State Legislature or the Federal Congress pass laws that enable some level of cost sharing enhancement for our plans. And at that point, I would like to, or we would all like to have input from our stakeholders and work group members on that topic. So given that we won't have had an opportunity to give you 30 days notice, I'm just going to say that will be virtual. Additionally, we don't know if laws are passed on this subject, whether or not it will align with our Plan Management Advisory Work Group schedule. So we may need to put together a last minute benefit work group, and we've done that in the past. And we will send out notices to everyone, maybe on very short notice, maybe only a day or two of advance notice for that meeting, depending on when the information comes out from the legislature and when we need to start implementing things internally. But want to make you aware that that's an approach we will have. So don't currently expect a Plan Management Advisory in July, but we may have to do a virtual something, either that or the Benefit Design Work Group subcommittee, whatever you want to call it, to get that one element resolved on a very short notice, and that will be virtual, of course. And with that, I am done and ready to hand it back over to Rob, unless people have questions or concerns.
Any questions? Okay. We have shorter than usual meeting today, 2 topics to go through. On the next page is the agenda, and we'll get right into it with Katie for an update on the affordability contingency planning. Katie?
Thank you, Rob. I thought this was going to be a little more boring than it's actually might turn out to be, and just picking up where James left off. We are closely following what's going on with the state budget. So what we were going to share was essentially what we shared in the May board meeting, about the May revision proposal for premium subsidies, but we do have some late-breaking information from yesterday afternoon that will impact cost sharing. So I'll just speak to that. We don't have slides on the cost sharing piece. But for May revision, the governor's release in the middle of May called for a premium subsidy program that essentially looks very similar to the premium subsidy program we had in effect in 2020 and 2021, with a modification to provide some additional support for individuals between 400 and 600% of the federal poverty level. So this is going back to what we had before the American Rescue Plan premium subsidies were enacted in 2021. And the proposed funding level for that is $304 million. And this is based on the contingency that we need to plan for if the American Rescue Plan premium subsidies aren't extended past 2022. As we know, they're scheduled to sunset under current law at the end of this year, though there have been discussions about extending them. So this is the contingency if ARP premium subsidies do expire. And we can click to the next slide for details. So we're showing you the required contributions and a little bit of the summary information about the structure of the premium subsidy program. Very similar to 2020 and 2021. We would eliminate the cliff, the ACA tax credit cliff for enrollees with income between 400 and 600% of the federal poverty level. But we would, unlike the 2020 program, we would cap out the required contribution at 16% for enrollees with income between 500 and 600% of the federal poverty level. That slope used to rise up to 18% in 2020. So that's a little bit of extra support for individuals with middle income. There would be a slight adjustment for individuals under 400% of the federal poverty level, where their required contribution would be 9% of their income for a benchmark silver plan as opposed to 8.9%. That adjustment finances the lowering of the required contribution at the middle income. And then consistent with our original design for the small number of individuals under 138% who are eligible for premium subsidies but not for Medi-Cal, their required contribution for a benchmark plan would be 0%. So those are the details of the curve and the contributions in the premium subsidy program as proposed in the May revision release. Let's go to the next slide. Just as a reminder for folks, we operationalize the state premium subsidy program through a program design document that is adopted by the Covered California Board and is then routed through the Director of the State Department of Finance and the legislature for formal approval to make sure that it's consistent with the state budget authorization or appropriation. So we have taken the May revision proposal, reflected it in the program design document that had a discussion meeting with the board in May, and our intention is to bring it back to the board next week, assuming we have some clarity on the budget to get that final approval so that we have that sort of contingency locked down and ready to go in the event ARP premium subsidies aren't extended. Let's go down to the next slide. We just have a couple of key dates here, which I think this committee is very familiar with. So I'll just pause here. The rest of my update is going to be verbal and it's about cost sharing. So the May revision is the administration's updated budget proposal for the upcoming fiscal year. The legislature has now, as of yesterday afternoon, released their language. And in the Covered California item, they're proposing to add a contingency that would say if ARP premium subsidies are extended, that $304 million that's been put aside for Covered California should be used for enhanced cost sharing. So again, this is late breaking, but fortunately we've done a ton of work to enable technical assistance now on a short turnaround. So I'll tell you what we're doing on the Covered California side. We are re-looking at the enhanced cost sharing options that we developed in AB 133 and then updated for the board last month. So we're looking at the enhanced benefit designs. As a reminder, we took several enhanced designs, including our silver CSR variants without deductibles, and some different actuarial value products, including what would be an 80 actuarial value. So we're looking at the benefit designs, we're looking at the program design options, and trying to figure out what would be the option that would get us closest to that $304 million target. We're also reviewing the structure and law for the financial assistance program that Covered California can run with state funding. That structure was set up in 2019 when we first established the state premium program, but the statute is sort of broad enough to encompass cost sharing. And it also talks about the fact that financial assistance under that program can be provided to individuals up to 600%. So we're sort of looking at the structure that's already been set up by the state and the $300 million amount for the upcoming plan year, and trying to figure out from a technical assistance perspective, what is the best option that we can discuss with the administration and the legislature as they have questions for us about this. So that's a little bit of the fast drill that we're doing right now. If the administration and the legislature reach an agreement on this by the time for an on-time budget, then we would be able to add this information into our program design document. As James said, this could be very fast and we might have to share things offline. But this is sort of the crunch we're in right now, and trying to figure out just how we can meet the requests and the needs of the administration and the legislature as they get down to their final negotiations for the budget for next year. So I'll stop at this point and see what questions or clarification anybody has.
Hey, Katie, it's John Newman from Kaiser. The last time we talked about cost sharing reduction options, and it seemed like the folks working with the legislature had settled on the AB 133 option 5, which would leave the CSR plan designs as is and simply change the federal poverty level required to meet the CSR level. Is that still where you think we are, or are we actually contemplating changing or adding additional plans?
I think we might be in that latter camp. And when we did discuss this, yes, there was the sense of, well, that sort of lift and shift using the existing designs would probably be operationally preferable. I think we're in a situation potentially, though, where those lift and shift options are too expensive for the budget we have, or they sort of don't go far enough to spend the appropriation that's been put out there of the $304 million. So at this point, as Covered California, as our staff is looking at options that could meet that appropriation amount, we are looking at the enhanced designs that we took to the board in May.
Just as a quick reminder, from an implementation operational perspective, it is getting really close to being too late to be able to pull that off without major unintended consequences. So anyway, just wanted to remind folks of that.
Yep, John, similar on our side. I think that the technical assistance that we've been consistent with is that we need to have this clarity by the budget deadline so that we can pull it off, all of us collectively.
Are there other questions?
No, Rob, I don't see any hand raised or any questions typed in at the moment.
Katie, it's Rob, Rob Specker from Blue Shield. Just, is the thinking for early July then, when the budget should be finalized? Like, do we have a sense of time frame of when we'd come to a collective decision of the additional plan designs?
Yeah, and I don't want to swim too far out of my lane on the budgeting process. The legislature's deadline to pass the budget is June 15th. We were sort of tracking discussions between the legislature and the administration about whether that might go longer. But what we've said is we're looking for as much clarity as we can have from the three parties, the Assembly, the Senate, and the administration by June 15th.
Got it. It does look like Diana has a question. Diana?
Go ahead, Diana, you were unmuted.
Diana, if it looks like you're having trouble with the audio, maybe put your question in the chat function. Diana, can you, are you unmuted now? Okay, we will come back when we can get Diana's question. Any other questions or comments? Okay, Katie, thank you as always, and the entire Cover California team for your help and leadership navigating through this. Very much, much appreciated.
Rob, we have Beth.
Oh, I'm sorry, Beth?
Yeah, yes. Diana and I have been working closely on this. I'm not quite sure what her technical challenge is. I think, as Katie noted, the legislature's joint agreement acknowledges that as of yesterday afternoon, if the federal subsidies are continued, then we'd have state help for cost sharing. We're certainly mindful of the standard benefit designs, but also very supportive of getting to zero deductibles for everyone we can get them for, including at the lower end of the income scale, and trying to balance those things. And as Katie rightly said, work within the budget that's available and the timeline that's available. So since this is all a bit of a moving target and it's hard to say anything more. I would say we're also still hopeful, although it's not guaranteed, that the federal AARP subsidies will be continued, which would then put us in the happy place of being able to provide Californians more help rather than less. And Diana may have things to add. Since she was having technical challenges, I thought I'd step in. Thank you.
Thank you, Beth. Any other questions and comments? Okay, Jan, if we can hand it over to you for an update on the MAPIA testing.
Great, thank you, Rob. And so I'll just be providing a quick update on the mental health parity testing that happened with one of our healthcare issues that will impact our 2023 benefit design. So Sana, I think we can move on to the thank you. So each year, our health plans, they conduct a rather complex calculation process for mental health parity testing. And so this year we do have the outcomes of one of the mental health parity testing will require one of our health plans to adjust their benefit design that is outside of our 2023 patient-centered benefit design. And so this is just a quick overview of the mental health parity law. Both the state and the federal laws require health plans to provide treatment for mental health and substance use disorder condition. The federal Paul Wellstone and Pete Dominici Health Plan Parity and Addiction Equity, otherwise known as MAPIA, is a federal law that requires health plans to apply similar financial treatment limitations to mental health and substance use disorder benefits and medical surgical benefits. So for example, if a group health plan offers a medical and surgical benefits, and they also offer mental health and substance use disorder, the plan may be required to follow the requirements that is under MAPIA. The California Mental Health Parity Act requires commercial health plans and insurers to provide a full coverage of treatment for all mental health conditions and substance use disorder. And it also establishes those specific standards for what constitute medical necessity treatments. So MAPIA basically requires that if health plans provide mental health or substance use disorder benefits, it prevents them from placing limits on those benefits that are less favorable than the limits that are placed on medical and surgical benefits. So next slide, please, Sana. So annually, each plan, they conduct their own parity testing using their claims data. And so plans may have different outcomes based on their claim experience for that year. And so there's results vary year over year, and it can also have different outcomes based on the plan design, or the plan product, I should say. So MAPIA requires the health plans to meet the mental health parity standards in several areas. First, the health plans must ensure that those financial requirements, and so this is stuff such as co-payments, co-insurance, and the deductibles, and the quantitative treatment limit, which is the number and the frequency of visits, if those are applied to the mental health or substance use disorder benefits, that they cannot be more restrictive than the requirements that is applied to most of the medical and surgical benefits. And then there's other standards such as NQTL, which is the non-quantitative treatment limit. So these are things such as, for example, prior authorization. And so prior authorization for mental health and substance use disorder must be equal to or less restrictive than those that are for medical and surgical benefits. So these standard applies to the following classification of benefits. So this would be for inpatient, for both in and out of network, for outpatient visits as well, for in and out of network, also applies to emergency cares, and also for prescription drug benefits. So Sally, can we move on to the next slide?
Yes, Jen. I'm having some technical difficulties. Hold on a second.
Okay. Yeah, I noticed the slide went.
Yeah, the slides were.
Yeah.
Okay, we're back.
Okay. Thank you, Sana. So as Kaiser was developing their portfolio, they determined that in order to be compliant with the MAPIA requirements, they needed to eliminate the cost share for mental health and substance use disorder benefit in outpatient classifications for two of their plan designs. This would be the CCSB Silver 70, and also for the bronze product, which is applicable to both the CCSB and the individual market. But when they had to reduce the cost share to $0 for outpatient office visit for mental health services to meet the MAPIA requirements, these two plans fell outside of the allowable AV de minimis range. So the main factor for Kaiser that drove this change was an increase in the utilization of $0 benefit services on the medical and surgical side, specifically around the telehealth encounters, for which Kaiser does not charge any cost share for telehealth services. So when they did their calculation using their claims data, this is what drove their mental health parity calculations to set the mental health substance use disorder outpatient office visit at $0. So our endnotes in our patient-centered benefit design, specifically endnote number 21, it permits deviations from the standard benefit design for services that are subject to MAPIA compliance, because making minor adjustments to meet the MAPIA requirements is not new, but this is the first time where the plan designs were impacted to the point that they needed to adjust their benefit designs that differs from Covered California standard benefit design in order to meet both the MAPIA and the AV compliance. And so we are planning to bring this to the board next week to make sure, because we are making some minor conforming edits to capture situations like this in the future that may occur from time to time if it's needed for health plans to meet with MAPIA compliance. So in order to bring these two plans back into the AV range, Kaiser will be modifying their plan designs. And when they came up with these design adjustments, they came up with these adjustments where they felt that had the least amount of impact to the consumers. So starting with their Silver 70 HMO product, I looked at the numbers, I think, just yesterday, and the numbers are about 12,600 individuals are enrolled in the Silver 70 product. And so their proposal is to increase the drug deductible from $300, which is in the standard benefit design, to $370. And the rationale is that most of their physicians primarily prescribe generic medication where medically appropriate, and as this is more affordable. And so following this pattern, obviously the tier 1 drugs also in this standard benefit design is not subject to the deductible in this plan. And so even if we were to increase the drug deductible to $370, it would have the least amount of impact to consumers who are most likely being prescribed a generic drug that is in the tier 1 classification. And then specifically for the bronze product, there's about 155,000 Kaiser members enrolled in the bronze product for both the CCSB and the individual market. And so their recommendation is to increase their maximum out-of-pocket to $8,600, which is about $400 higher than what we currently have in the 2023 benefit design. And the rationale for this adjustment is increasing the maximum out-of-pocket by $400 allows Kaiser to just make a single adjustment to the plan and minimize the impact to the consumers. So next slide, please, Sana. So this is just a visual of what I just talked about on the bullets on the prior slide. So you can kind of see in the CCSB product, the deductible is $370 and the mental health services now would be set at $0. And for the bronze product, the maximum out of pocket is now at $8,600 and the mental health services are now set at $0. Last slide, please, Sana. So I will be sharing Kaiser's modified benefits to the board next week for awareness, and it will be an information item only. We will have an action item on a couple of items, mainly pertaining to the revisions on the benefit design endnotes. And so a quick recap, back in April, a couple months ago, I had shared with the Plan Advisory Group that we needed to make an adjustment, or was it just, I'm sorry, I think it was just last month, sorry, that we needed to make adjustments to endnote number 31 to edit the language to state that the MOOP in the bronze HDHP, as you can see highlighted here in the blue, shall not exceed the MOOP specified in the IRS revenue procedure. So IRS issues their annual limitation on cost sharing after we had proposed the 2023 benefit design to the board. And so we had informed the board back in April that the benefit designs were still in draft until the final release of the MBPP, the AV calculator, and the IRS notification on the MOOP limit for high deductible health plan. And so if there were any significant changes, we told the board that we would be bringing those items back to them for discussion. So in late April, the IRS set their limit at $7,500 for the maximum out of pocket, which is higher than the Cover California standard benefit design that has a MOOP limit of $7,000. So Cover California determined that we want to keep that $7,000 MOOP limit, as this is a better benefit for our consumers, but this will require a change in the end notes. And so this minor technical change will allow Cover California to maintain the $7,000 MOOP limit in our high deductible health plan, rather than adjusting our plan design to be equal to the IRS notice. And additionally, we will modify the plan design themselves, because under the dollar amount for the high deductible health plan right now, we have a reference to go see the end notes. So we will replace that text by putting the actual dollar amount of $7,000 for the high deductible health plan. The second change that we're making to the end note is making conforming edits to end note number 21 to capture situations that I just talked about, like today, that may come up from time to time if changes are necessary to comply with both the California Mental Health Parity Act or the federal MAPIA rules. And this language will allow Cover California for us to work directly with our health plans to make changes as necessary that would have the least amount of impact to consumers. And so that is my final slide, I believe, and I'm open it up for comments or questions or discussion.
Hey, this is Diana with Health Access. Can folks hear me now?
Yes.
Yes, Diane, we can hear you.
I'm sorry about the technical difficulties earlier, but just wanted to pop on and say that, you know, we, from the consumer perspective, of course, don't like to see the shifting around of and the increase in the drug deductible and the MOOP, but understand that these are necessary to bring into compliance with parity. So, you know, appreciate the work to find at least a balanced way to bring the AV within range. And that I do think, though, that this does kind of flag the need to have conversations about, you know, the impacts on the overall AV as we're looking at cost sharing being reduced elsewhere. So hope that we can just continue to look at that, and with regards to telehealth and other services and how that might impact AV in other ranges in other areas when we need to make adjustments like this later on in the game. But while we're not happy about it, we you know, understand the necessity for it.
Thank you, Diane.
Dan, this is Carrie. Can you hear me?
Yes, Carrie, we can hear you.
Great, thanks. I just wanted to add on to Diana's comments to say, you know, we understand the need for the changes. We don't love these changes, but understand that, you know, this is an exception. But we hope that it is an exception, and that, you know, moving forward, we can, you know, make sure that this type of, you know, issue because of zero cost pays for telehealth, that this is something that is figured into earlier on what the final, you know, benefits and costs will be. And of course, we realize, you know, we need to have probably a longer term, a larger discussion about telehealth moving forward. But of course, you know, want to see data on outcomes for consumers, so that whatever payment policies, you know, are being put into place and supported are in the best interest of consumers. Thank you.
Great, thank you, Diane. Definitely welcome future discussions on telehealth services. And I think it is time for us to have a more robust conversation around telehealth services and impact of that as well. Thank you.
Hi, this is Hector with the National Health Lab Program. I just wanted to echo Diana's and Carrie's words on this issue. So we don't have a specific issue with the proposed modified benefit design. It is certainly not ideal, but it looks like to be the least disruptive option while ensuring compliance with parity, which of course is so important. And I wanted to underscore that as a behavioral health advocate, we really appreciate that plans are ensuring that they are complying with MAPIA and with parity rules. So even though it's not ideal, the result in the benefit design, we understand the need for it. But that being said, I do want to echo the calls to evaluate how plans are approaching telehealth benefits, so that we really try to ensure that there are uniform rules to avoid situations like this one in the future. Just as one example of things that we have raised in the past, advocates have shared that cost sharing for telehealth should be equal to cost sharing for in-person, not lower, which is currently allowed under Cover California contracts. And to the extent that this is having an impact on MAPIA testing, we think that should be revisited. So this is just an example. I think there are other global, more uniform options that should be preferred over more ad hoc modifications that really defeat the purpose of the standard benefit design. Thank you.
Great, thank you so much, Hector. Sana, do we have anyone with typed questions in the chat?
No, Jen, we don't have anyone with questions typed in or even raised hands.
Okay, thank you. So if there's no further comment, I think, Rob, I would turn it back to you.
Great, thanks, Jan. That actually brings the end of the content that has been teed up. Are there any other topics that work group members or board members would like to raise for discussion? With that, with none raised, I will thank everyone for your participation today, and we'll bring this meeting to a close. Thanks, everyone.